As you can imagine, if you're a doctor taking care of patients with cancer, it is just not easy. This week, we're bringing on Dr. Kevin Raskin, who's an associate professor at Mass General Hospital. He's the chief of the oncology service there. He's been there for 20 years. He takes care of all of my patients locally. He literally has trained with the giants of musculoskeletal oncology, Henry Mencken, Dempsey Springfield, Fran Hornacek, as well as Mark Gebhardt. And he just has an incredible passion. I love his story about how he shares his successes and his failures and how he manages both personally and professionally, but how he cares for his patients, gives them solutions, really letting them know that there's a team approach that's available that's going to help these patients. I really enjoyed this episode. It's not for everyone to be able to understand this, but I think that his passion for being able to share his story is a great one. You will enjoy this. Dr. Sigman, #FollowTheFro.
From medical media, this is The Ortho Show.
Hello, world. Dr. Scott Sigman, your favorite opioid-sparing orthopedic surgeon, here for another episode of the Ortho Show podcast, where everyone knows we bring you the best of the best. We're not going far today. We're going right down to Boston, 20 miles right down from my little podcast studio here with Dr. Kevin Raskin, who is the chief of orthopedic oncology at Mass General Hospital. He is an associate professor at Harvard Medical School and longtime fellowship director of the orthopedic oncology fellowship at Mass General Hospital as well. Kevin, what a pleasure it is to have you on the show. Thank you so much.
My pleasure, Scott. Thank you very much for having me. I really appreciate it.
Yeah, no, it's my pleasure. Look, we always start at the beginning. We like to know, where and when. Where'd you grow up? Were there doctors in the family? How did you do this whole orthopedic thing? Give us a little synopsis about where it all started.
So I grew up in North Hollywood, California, which is in the Valley. Whenever I say North Hollywood, people think, oh, Hollywood. Wow, how great. Not so great, frankly. North Hollywood is not anywhere near truly Hollywood. It's pretty central in the Valley, a lot of strip malls, and not so remarkable, frankly. I got lucky, and if I could use any four-letter word over and over again on this podcast, it will be luck, because it's truly luck that I'm sitting here right now, wearing this jacket and in this environment. In North Hollywood, no one in my family is in medicine, although my father had a first cousin whose husband was a vascular surgeon. So I suppose my extended family. And I was fascinated, even as a little kid, by him, by his work, he was always missing. He was always gone. And I always thought, I didn't think like, God, poor, his name was Robert Harris. He's since passed away, in fact, just recently. I never thought, well, poor Bob, he misses all this family stuff. I always thought, what's Bob doing? It's like, this is, a Sunday at 1 o'clock in the afternoon, he's operating on somebody. And I thought to myself, that's cool. I just, rather than cooking burgers in the backyard.
So very early on, there was some exposure for you. You were excited by it, which is interesting because it's sort of not the immediate family.
No.
But you're growing up in the Valley, and then it's UC Santa Barbara for undergrad. So you're going to stick around, which is obviously one of the most beautiful spots on the planet. That had to have been an amazing, 4 years. And was it from that moment, like when you're at UC Santa Barbara, you're like, okay, I'm going to medical school. This is my path.
No. So,
okay.
So, typical Kevin Raskin, like I have this dream, but then I think, I can't do this. Who am I kidding? I'm from North Hollywood. I don't have a chance. So I get this job at a hospital in Santa Barbara, and this orthopedic surgeon by the name of Don Fareed, who is a lovely, lovely, wonderful guy who really made my life. He didn't save my life. He made my life. He took me under his wing. I was literally mopping floors and making coffee. And next thing I know, I was working in his office. And come graduation, filling gauze containers and cleaning the rooms. And at graduation, he said, what are you doing? And I said, nothing. I don't have anything planned. I took some medical school prereqs. I hadn't taken the MCAT yet. He said, well, look, I used to work in this basic science lab down at UCLA with Marshall Urist. And I, of course, have no idea who Marshall Urist is. He said, if you want to do some research, I'll give him a call. And I thought, yeah, just tell him I'll be there. And I went and moved back in with my mom and dad. And for 2 years, I worked with Marshall Urist, who, as you know, Scott, is a big timer. And I had no idea. You know,
That's the way that's the way it is a lot of the
yeah,
time. You know, you just sort of get thrown into this thing. You're not sure who it is. Turns out it's some world-renowned dude, and you just happen to be there. But I love it. So go ahead.
No, sorry. He discovered BMP. His lab was massive. He had a huge footprint at UCLA. And I thought, all right, I'm doing this. This is wonderful. I love it. But it took some time for me to figure it out. And so after a year in the lab, I finally applied to medical school and was waitlisted up and down, left and right. And there was an Israeli guy in the lab who was going to Sackler, which is a American program in Tel Aviv.
Tel Aviv University, the Sackler School of Medicine, just so our listeners understand. Yes, I was wondering how we got to Tel Aviv, but keep going.
So he said, you should apply. It's great. It's an American program. If you don't like it after 2 years, you just transfer back. And I thought to myself, all right, I'll just do that. Because if I don't get into these schools that I was on the wait list for, then I don't really want to spend a third year waiting to go to medical school. So sure enough, in July of '93, that is in fact the only school I was accepted to. So I told my mom and dad I'm moving to Tel Aviv, and I bought a plane ticket, and that was that.
That's super cool. I mean, you got to admit, that's a very unusual pathway for medical school. I have to say, you are the first Ortho Show alum to have that direct pathway to Tel Aviv. Now, first, is it still called the Sackler School of Medicine, or did they pull the name? I'm just curious.
It is.
Really. So for our listeners, the Sacklers are the family for Purdue Pharma, which all of these movies and things have been all about, with OxyContin and Oxycodone and all that kind of stuff. So interesting that the name has not changed where it has at so many other facilities.
It has not changed.
So
I was there not too long ago. It's still there, yeah.
So 4 years in Tel Aviv must have been a really remarkable experience for a young man who's just trying to figure life out.
Awesome. I mean, dare I say, the best 4 years of my life. And this is with, 3 kids and the wonderful practice and life here in Boston. But it was, I was thinking, all right, 2 years, I'll just pull up stakes and go back to the States. But after 4 years, I thought, why am I going back to the States? This place is fantastic. I love it here. The education was outstanding. The people are beautiful. The culture is wonderful. The experience was, I felt bad for other medical students who couldn't be there, frankly. It was out of this world awesome.
So all right, but it's an American program, but I'm still thinking that you're a foreign medical grad.
Totally.
And how are you getting back into residency into the States based on a 4-year degree out of Tel Aviv?
It was very difficult. So in medical school, I completely changed my path, and I thought I wanted to be a general surgeon. Orthopedics, well, I'll put it to you this way. I just was more influenced by the general surgeons in medical school in Israel than I was the orthopedic surgeons. And I thought, that's such a big thing for a medical student, is who do you identify with? With whom are you finding yourself most like? And in Israel, it was the hepatobiliary surgeon at Ichilov Medical Center, who I thought was wonderful, and I wanted to be like him. So I decided I wanted to be a general surgeon. So I applied in general surgery and landed a spot at Montefiore in the Bronx. And I quickly realized that general surgery in the Bronx, New York, was quite different than general surgery in Tel Aviv. It was pretty rough. The Bronx is a great place to train, kind of rough. And the general surgeons were just not my people. And I wasn't sure what I was going to do. Was I going to just do it and stay on? And sure enough, this orthopedic resident quits. And like the day before he quit, he said, Raskin, I'm quitting. And, I know you worked in Urist's lab and you have this orthopedic thing in your past. Why don't you just switch? He said, if you want, I'll talk to the chairman. I said, okay, sure.
All
And
right, so
like,
here the word luck. I'm seeing where the theme is coming from at this point. We seem to be hearing a lot of this at this point.
total luck.
So you make the switch, they take you, you get traded for a first round pick later on or whatever. Was Spike Foreman, was Spike the president of Montefiore and Albert Einstein at the time?
In every way.
So Spike is the father of one of my best friends in the world from high school. I grew up with
Wow.
Spike, and his son is Todd Foreman, and Spike was the president of Sinai Hospital in Baltimore. And then they were looking for someone to come to Einstein. He took the job. It was a huge job, really. And so really, like, very pleased to know that you knew Spike as well.
Well, I knew him. He didn't know me.
Yeah,
That's
yeah,
for
of
sure.
course, of course. Right, right.
Yeah, he's a big deal. Very, very, very smart guy.
Yeah, he subsequently passed, but yeah, no,
Yep.
we miss Spike very much. What a great
Very
guy.
bright man.
Yeah, for sure. So, all right, so you get into orthopedic residency at this point now. God bless you. Somehow you figured out a way. Most people have to do 3 years of fellowships and other stuff to get in, but you have some way to get in. You're into orthopedics. And so at what point, like it's so rare, Kevin, for people to pick a specialty of oncology within the orthopedics. It's just not a common pathway for most. So at what point did that sort of spark go for you when you thought that oncology was the way to go?
Right. Well, frankly, I had a hard time in orthopedics in the beginning, not technically, not intellectually, but culturally in a way, spiritually to some degree. Here I was spending time thinking about patients with pancreatic cancer and bile leaks and, these intra-abdominal catastrophes. And then now I'm in clinic with, Mrs. Schwartz and her shoulder pain. And I'm thinking, okay, all right, have a little cortisone and a pat on the back. And, it took me a while to learn to appreciate pain and disability as a disease set. For me, diseases meant liver cancer, colon cancer, ruptured viscus. Like that was a real cancer.
And that came from your previous experience. I mean, you're spending
Totally.
time in Israel with the general surgeons. That's what you're growing up on. You're seeing. We were, in that age as well when we were first, because we're contemporaries. I'm 5 years older, but pain was the major topic within medicine. It was the issue of our generation, right? We
Yeah.
were all told we have to treat everybody with narcotics and opioids and all this other stuff. So I find it fascinating that what is really attractive for a lot of orthopedic surgeons, which is to take somebody that has a demonstrable problem that you can fix relatively easy and get them back out to society. That's the common answer as to why people go into orthopedics. For you, it sounds like you were more interested in the complex issues that weren't so easy to figure out.
Right. But I did ultimately grow an affection for all the orthopedic, the gamut of orthopedic problems, because they're problems. People, somatic pain hurts. It bothers people. It ruins their lives. But it took me a while to adapt and adopt and adopt the culture of orthopedic surgery, of getting people moving, getting people to feel better, not because they have some dastardly disease, but because they have arthritis, which, thank God there's a solution for, frankly, in total joint replacements, et cetera. So it took a while, but in the end, my heart was with bigger cases and bigger problems, and I couldn't resist oncology. I knew it when I first started reading about it, and when I scrubbed on some cases, I thought this is exactly what I want to do. This has both the gravitas of where I came from and all the orthopedic stuff that I grew to like and enjoy.
And God bless, because there's just not that many people that want to take on that gravitas. And so off you go to Mass General Hospital, to arguably one of the premier orthopedic oncology places in the world, right? You have Henry Macon, who is the chairman of orthopedics, who is the godfather of orthopedic oncology. You've got Dempsey Springfield, who's there at that time as well. Mark Gephardt, who I think would pop in and out, but he was more sort of at Children's and around. And was Fran Hornacek there at the time yet?
Oh yeah.
I mean, dude, I mean, that's like the Avengers of
Yeah.
orthopedic oncology. I mean, it couldn't get any better than that.
Yeah. I had no business being in the same room with those guys. Uh, but
And most of the time you didn't want to be because God knows what they were going to ask you.
well, you make yourself available, you demonstrate some competence, and next thing you know, you're in the conversation because
Yeah,
the problems are hard. And even the
yeah.
great Henry Mencken and Dempsey Springfield, they need help too. And I was here to help. I was here to take call and manage problems. And I realized that orthopedic oncology, in its wonderfulness, is also it generates problems. And I tell my fellows, you are doing a fellowship in complications because
We're gonna get to that because that's one
yeah,
of my big questions that I was gonna ask, right? This is not rotator cuff surgery with, if it doesn't work, you still have a rotator cuff tear. I mean, we'll get there. I think that's super important. But
right.
let's talk a little bit still. Like, as a fellow, you were had to have gone to Mencken breakfast as well, right? You were there every place he was. So tell us
Yep.
about your experience with the Henry Mencken breakfast in fellowship, because I can tell you, I was there too for a little bit.
Well, it's terrifying because I mean, look there. That's Henry when he was in Pittsburgh, and that's the kippah from his funeral.
Mm,
I mean, I grew to love him from the moment I met him because I realized his genius, just like that guy over your left shoulder.
mm.
He's a genius. He just saw things that no one else saw, and I just knew that that's the kind of person that not that I wanted to be like, but I just like to be around. His cleverness was so compelling. So I was able to, yeah, sure, he's terrifying because he could make you feel an inch tall in 1 second. And God help you if you demonstrate, if there's blood in the water, he will continue, he will chomp. And he did.
So just so for the listeners, describe what this is, right? Because as a Tufts resident, they would send us over there for trauma, and we would have breakfast with Henry too. 3 to 6 months. Levine will yell at me
Yeah.
because I can't remember how long, but we'd have breakfast every morning after rounds and before surgery, and they put up a case. But just describe it because I think it was amazing.
Well, it was a case, whatever the case would be, whether it's a non-ossifying fibroma in an 8-year-old or a Ewing sarcoma in a 14-year-old or a chondrosarcoma or any lipoma. He would just begin almost like the oral board experience in Chicago. It would just be this layer by layer questioning and peeling away of your knowledge. And it was relentless until he got to the part where you ran out of knowledge. And then, irrespective of how many layers he got through, he could have asked you 6 questions that you got right. But it was the 7th question that you got wrong where he would shake his head or call you a moron or he would say, you're a good dog, but you're a dog that needs to learn more tricks. Something like that.
Well, I'd be sitting there drinking my coffee in the back of the room, keeping your head down. Who's going to get called this time?
You wanted to be as anonymous as possible. Listen, I would be lying if I said there were more than a handful of times where I saw him down the hall and I took a hard right just to avoid him because I thought, I just don't need to confront him right now. I have enough on my plate that the last thing I need is to run into Henry and have him dial me up with a question or a task or, Mrs. Jones needs something that is impossible at 6 p.m. on a Friday afternoon.
Yeah, I mean, and this was hard times. I mean, we as fellows and residents back in that age, there was a lot of service that we provided to the hospital. We would put IVs in, we'd be drawing blood, you'd put Foleys in, you'd be running labs. I'm like, nowadays there are all of these other people that do that ancillary service. So it was really hard work. I mean,
Work.
120 hours a week, on call, never around. I mean, it was not easy back then.
Hustling, work.
Yeah.
Yeah.
Hard work. All right. So look, let's get right to one of the difficult questions, right? Because for me, we've had some James Whittick on, we've had some other people on, and caring for patients that have a diagnosis of cancer, it takes a skill set, right? These patients come in, they've been told by some other doctor somewhere, something looks funny on your x-ray. I'm not sure what it is. I'm hoping it's not cancer. It might be, but now you have to go to Mass General and see the guru, Dr. Raskin, so he can explain. So walk it through for our listeners, because how's the impact for you personally, and then how do you sort of talk through this with your patients?
It's an excellent question. It's a little bit hard to organize one's thoughts about that, but some things to keep in mind. One thing is that patients don't catch cancer in your waiting room, meaning they, for them to come see me that's what they're doing that day. I might see 20, 25 patients in an office day, but for each individual person, especially a new patient, they've been waiting for this day for days, and that's what they're doing. So I know that I have a lot of value I could offer them just in my time and in the ability to sit with them and listen to their story and at least name their problem. And one of the tendencies is to think that a complication, a new diagnosis of cancer, or a metastasis is something that happened on my watch, that it's my responsibility. And certainly there are things that I have a hand in that create problems, but it's never a new diagnosis of cancer. So I see myself as someone who in the immediacy of the problem is helpful. And I'll often say, we have a lot of adjectives, but no nouns. We need a noun for your problem. So I immediately set in motion a plan for patients with an MRI finding or a mass or pain or both. And the plan is really, I think, empowering. Knowledge is power. The more you know about a problem, the more you feel that you're empowered, that you can do something about it. And that helps patients feel less unmoored. They feel that someone is going to take care of them, that they have a plan, that they could, in fact, beat this. So initially in meeting patients, I think of my role as someone adding value. I can appreciate this problem as one that I can solve, and I'm going to show you how I'm going to solve it with help from my friends. We have a big team here with whom I work: radiologists, pathologists, medical oncologists, radiation oncologists, and we bring in people as needed. And if a biopsy is needed, for example, then I work like hell that day, that minute, to get it done right then and there. That's critically important, I think, to have them go back to Lowell and come back 4 days later. That to me is stressful and anxiety provoking. And if I can't do the biopsy myself in the office, then I try and find a radiologist who can. And we're very, very fortunate here to have a team of people who are willing to, in the moment, come down and do an ultrasound guided biopsy and get the ball rolling. That's empowering and makes patients feel safe.
I really love that, because, we all sometimes just sort of focus on being the carpenter, right? And at the end of the day, there's a patient attached to that tumor, and they have loved ones, and they have anxiety, and they've been thrust into this. They have no idea. So all of these things that you're providing for them, your time, your ability to name this thing, your ability to provide them an immediate pathway to do something to help. And talk a little bit more about the team approach, because I think the team approach in oncology is critical for being able to help our patients to be able to make the right diagnosis, and then also decide about treatment, right? First, you got to figure out what's wrong, and then is there a team of people that get together in a tumor board that help to make all these decisions?
Critical, all critical. One of the first things I'll tell fellows who graduate when they ask me about a job, hey, Raskin, what do you think of this job? I ask them, what's your team look like? Who's there? Is there a medical oncologist? Is there a plastic surgeon? Who's there? Or do you have to build this from the bottom up? Because you cannot do this alone. Impossible. So we have radiology conference, 9 a.m. Tuesday morning, where we talk about every new and any interesting radiological finding that needs to be discussed, where we talk about biopsies and biopsy approaches with the radiologists, the orthopedic surgical oncologists, and the pathologists. The pathologists will bring cases that have been biopsied, or even cases that have even come from the operating room, and they'll want to review the radiology again. So it's the Tuesday morning conference is a working conference where we talk about radiological issues and pathological issues as they interrelate with not only us as surgeons, but even outside consults from around the world and around the country. Thursday afternoon at 4:45, is our tumor board, where only sarcoma cases are discussed. Sarcoma and some of the other nuanced orthopedic oncology things like giant cell tumor bone or pigmented villonodular synovitis, where there's a multidisciplinary approach. So those on Thursday evenings, medical oncology, radiation oncology, orthopedic surgical oncology, pathology. We'll talk about 8 cases, and we'll talk about, is there a medical oncology need? Is there a radiation oncology need? What's the surgical plan look like? What's the coverage plan look like? Is there a thoracic surgeon that's needed, a neurosurgeon? And we talk in great detail about the timing. Are we going to do chemotherapy first or radiation first? Radiation first or surgery first? Surgery first or medical oncology first? And there are some patterns. There are some cookbook things that we can rely on, like for osteosarcoma, we generally give chemotherapy first, 3 cycles, then we operate and then complete. But sometimes the cases are different. So every case is given its time and due. And all the options are on the table. And there's smart people from each discipline present to represent what they do and what they can offer the patient. And then Thursday evenings, it's one of the jobs of the fellow is to get on the phone and call the patient typically and explain to them what was discussed at tumor board. The patient knows they're being discussed at tumor board. They're waiting for our determination. And then the wheels are set in motion for the plan.
So a customized care plan by some of, world-renowned experts in their field at Mass General Hospital, where they specifically manage patients with orthopedic oncology. I mean, that's as good as it gets. And we're so fortunate here. I send my patients to you. I've sent 2 to you in the last 6 months. They drive 20 minutes down to go and see you, and people travel in from all over the world for the care that you provide. I'm going to give you one more tough question, then I want a couple of easy ones. But, orthopedic oncology, it's fraught with complications and difficulties and really maybe not always having consensus. And so you get sometimes poor outcomes, you get complications, you get infections, and yes, sometimes you get death. So how do you manage that personally as the physician? I know you can manage it with patients, but to be able to take on the responsibility of that, how do you move to the next patient?
Brutal. I had a resident ask me a number of years ago, do you ever feel burned out? He sat right here, right in front of me. And I said, every single day, even like 11 times a day, I feel I can't, this is it. I can't do it anymore. I'm going in, I'm going to write a book. I'm going to do something else. Yeah, sure. It is harrowing. In fact, we bring patients to the brink at times, both literally, figuratively, emotionally. We, in an effort to save limbs, we sometimes lose lives. Patients pass away from their disease. They can sometimes pass away from their complications, but not even pass away. Sometimes in an effort to save a limb, their lives are ruined because they become professional patients with complications of infections and surgeries and flaps and PICC lines and spacers, and that's not living. So sometimes an amputation, frankly, is life-saving in many ways. Look, I would never deny the toll it takes on me personally and emotionally, and I see it in my colleagues too. Like we want nothing but success for our patients, but at the same time, I know enough to know that if you put in big pieces of metal in big defects, you're going to get big complications. Mother Nature is not having it. And she will tell you just about every time. And I'm pleasantly surprised when it doesn't happen, but it happens. I know it happens. She is a toughie. And I'm grateful for the time she lets us get away with it.
Yeah, I mean, there are times, you have complications, but one of my mentors and professors, sort of pulled me aside and said, look, Scott, the only way in which, you can help the next patient is you need to find a way to file it away in your hard drive, find the goodness, and then move on to help treat the next patient. So let's talk about something that's more uplifting, and that is, how do you celebrate your successes, right? Because you must rely upon those successes to feel really good in that day when you personally are dealing with struggles. So what do you do? What do you do with the patients? What do you do personally? What does the team do? There must be some fun stuff that you do to help out and celebrate.
There's a lot of successes, and I have an office full of, I mean, this is a tchotchke heaven in here with so many gifts and wonderful things from patients to commemorate their time that we spent together. That's for me oftentimes enough just to know that what I know how to do has helped them in their life to have babies, to have just to have a life. That's enough. I don't need a ticker tape parade.
Diana.
Yeah. Yes. Could not be more appropriate, right?
Right.
I don't need a mariachi band to play for me as I walk into the office every day. We love our successes. We love them personally. We love them individually with my two other partners. But it's also, it's also just Tuesday, Scott. It's my job.
Yeah.
And just like the failures are the failures, the successes are the successes. And I got to get to Wednesday. So I go home and I do what I need to do to get to Wednesday. It becomes routine, oddly enough.
Well,
But
it is your routine.
it's a wonderful routine. I love it.
Yeah, you're saving lives and doing the best you can every day, and you celebrate the successes and you help with the losses as well. What is exciting you? We're about ready to leave and end our conversation, which has just been wonderful. What is really getting you jazzed up about orthopedic oncology in the near future that's going to be different, that's going to help to change the way in which you're working these days?
Yeah, that's a good question. Orthopedic oncology is probably the slowest moving technological field, mainly because of the disparity in patients we treated. So for me, 3D printing and pelvic surgery has been interesting. I have you see these models behind me. That has made pelvic reconstruction quicker, which is critical to the success of pelvic reconstructions.
Any cool things in chemotherapy? Some
Yeah.
new stuff that's going to go right to the tumor and kill it and all that good stuff.
Absolutely. Well, look no further than PVNS. There's pexidartinib, which is a CSF1 inhibitor, which is, we almost never operate on PVNS anymore. Patients can either take this drug. It certainly has its share of complications, but it is extremely effective in reducing the disease burden. Just generally speaking, the targeted therapies are turning cancer on its ear. I mean, a patient with metastatic lung cancer, when I started in training, over 50% of them would be dead in 6 months. Now, I mean, all bets are off. If they have some of the mutations that are targetable, they will live for years, which is a paradigm shift. Lung cancer, melanoma, metastatic melanoma in 2002 was a real death sentence. Now, not even. If you have a BRAF mutation, there are drugs that specifically target that mutation, and you will live. It is turning cancer into a chronic illness, which is exactly where we want it to be. It's phenomenal what these drugs can do.
Well, no offense, but hopefully one day we're going to put you out of business, and your fellows are going to have to look for a different avenue other than surgery. But look,
Please
Kevin,
do.
yeah, right, exactly. I mean, look, Kevin, God bless you, man. I greatly appreciate. I'm so fortunate to have you as a colleague within my community. So I have world-class care for my patients, but your decades of experience in orthopedic oncology, your dedication to the education of residents, your passion for patients and being able to care for them and being able to deal with the complications and the successes. It's been a wonderful interview, and so happy that we're able to share this with our listeners today.
I really appreciate the invitation. I have tremendous respect for you and what you're doing, Scott. I appreciate it. Thank you so much.
It is my pleasure. This is Dr. Scott Sigman, #FollowTheFro, host of The Ortho Show. Till next time.